have any of you been to the American Academy of Otolaryngology? I'm sure many of you have. The American Rhinologic Society is always the day before the Academy, and it's in a nearby hotel. But you'll probably get, if you're interested in rhinology, you'll get more rhinology in one day. Now it's going to be a day and a half at the ARS than you will the entire week of the American Academy. So this is particularly important for those of you that really want to hear the latest in rhinologic innovations. And now they're cadaver. Now we've started in the last year cadaver dissections that are free and things like that. Also for the residents outside on the table, we put these little folders that look like this, and they've got some opportunities. I've been asked if there are dissection courses, and we do have an annual dissection course. You see all the way to the left. In January of the year, we certainly have our dissection book that's routine.com, and in our mini fellowship program, the 3 to 4 week mini fellowship program, where they observe and work on multiple cadavers. So there are educational opportunities available to you. And again, it's all listed in the white folders outside. What did I do here? Let's go back again. So, it's, for those of you that like scuba diving, actually that's me and my two of my sons, you know early on that when we scuba dive, we have to have landmarks to know where we are underwater. We do have a compass, but we still need to have landmarks so that we know where the boat is and how to navigate underwater. Sinus surgery is not unlike scuba diving. What are those things at the top? I don't know what these things are up here. It's funny being at a podium and sitting and standing and talking and listening to colleagues when they go out there presenting particularly revision cases, and you hear over and over again saying, well, these cases have no landmarks. Well, every case has landmarks, and we learned that early on as otolaryngologists, particularly our otology colleagues know that very well, that landmarks always exist for surgery. It's just that there's different types of landmarks. And this goes, as you heard yesterday, for the maxillary sinus, the sphenoid sinus, and even for the frontal sinus. And I hope to share some of these pearls with you after many years of experience, not just as a professor teaching students, but also as a professor learning from students to see what works and doesn't work for them when they're learning. The reason we want to know landmarks and the reason we have to know landmarks is because you never know when the worst thing can happen during surgery, and it can happen in the worst possible moment. As you're doing surgery, things can really go bad really quickly, and you certainly don't want that to happen to you in surgery. So it's very important to understand. So yesterday you learned a little bit about some of these landmarks. You learned, like the green line right here represents the orbital floor, and you know that if you follow that orbital floor posteriorly, it always leads you right over here to where the red line is, right there where they intersect, and that's the area of the natural ostium of the sphenoid. And you also know that this red line represents in a very important coronal plane, because a lot of things happen at that coronal plane. And by finding one structure in that coronal plane, you can find another structure. So if you're in the lower part of this coronal plane, you know that if you go laterally, you're going to go into the pterygomaxillary space. First of all, the sphenopalatine foramen, then the maxillary space, pterygomaxillary space right behind the maxillary. If you go superiorly up here in this area, this line is going to cross through the orbital apex and the start of the optic nerve, the canalicular portion of the optic nerve. Regardless of whether there's an anode cell or not, This plane is very, very important right up here. And of course, the line itself represents the plane of the anterior wall of the sphenoid sinus. When it comes to the frontal sinus, of course, it's this yellow line here. And this yellow line represents the coronal plane, as you saw yesterday, of just the anterior to the anterior wall of the ethmoid bulla, if it's present. If it's not present, then it's the area just at the level of the natural ostium of the maxillary sinus, which is only a few millimeters behind this oval yellow line and parallel to it, which represents the nasolacrimal apparatus. So when you're heading towards the frontal, you're really heading in the plane that's going to be at the coronal plane of the natural ostium of the maxillary, heading in this direction, just parallel to the nasolacrimal. Note that the nasolacrimal, this mucosa here, that's anterior to the attachment of the middle turbinate, is almost never involved with polyps. So in fact, we can almost identify where the lacrimal stops just at the insertion of the middle turbinate and when the normal mucosa starts, because it's just where the polyp starts. So it's a very important landmark. And of course, when we're doing these things, you know, you heard yesterday that the three things we use, not by itself, but in combination, are the colomellar measurements. We use that antrostomy ridge that we talked about to know where we are relative to the ethmoid cavity. And of course, the medial orbital floor, this white line that allows us to know that if we're above that line posteriorly, you're within 5 to 7 centimeters, you're going to be in the posterior ethmoid cavity. If you're below that line immediately, you're going to see that most of that sphenoid sinus is going to be below that line. So you have to know these relationships. And it's not that important when you see normal cadavers like we saw yesterday, but this will become more apparent to you when you start engaging in cavities that are bloody, that have polyps, and that have revision cases. These are the types of landmarks you use for revision cases. And of course, we know that we want to follow that floor of the orbit down here as the correct trajectory into the sphenoid. And in some cases, we want to go through the basal lamella, this portion of the basal lamella of the middle turbinate, in order to enter the inferior posterior ethmoids. And why? Because the first thing we want to do is we have to identify the orbital wall, the medial orbital wall somewhere. Because once you find that sagittal plane of the medial orbital wall, now you've got an identification where to go posterior and anterior and try to avoid damage to that structure. And these are two cases with polyps. These are the type of polyps you typically see in the northern part of our country, and more percentage. It's not to say they don't see these type of polyps, and you guys are very well familiar with this. Okay? This is AFS, right? This is what we see in South Florida, in the southwestern United States. This is what they see in the northern part of the country. Totally different. Polyps, these are polyps, may or may not be too inflamed, too inflammatory, too adherent, too fibrotic. These are very adherent, very fibrotic, very inflammatory, high residual chance of recurrence. These polyps, you can do any kind of technique you want. You can see here, you still have all the septations, lamellas as they refer to them, of the ethmoids if you wanted to identify them. You can still preserve a lot of mucous membranes because you see they're aerated. These, I dare you show me one lamella in this one. You can't use lamellas, you can't use turbinates, you can't use anything. The only thing that's intact there is the orbital floor, orbital wall. So you have to have a technique that uses the existing anatomical structures to navigate you, to guide you in the right direction towards the sphenoid, and right now we're going to talk about the front. Come on. So how about the front? In the frontal sinus, of course, we want to find the passageway of the frontal that's between two columns of cells. The one column is that of the uncinate process leading to the agonasi, and perhaps some more cells above the agonasis that we refer to as frontal infundibular cells. Okay? So that's one column. The other column that runs parallel to it is the ethmoid bulla and a variety of suprabullar cells that occur above it. some which are fairly pneumatized, some which actually extend over the orbit and can be fooled. A person can be fooled thinking it's the frontal sinus, where in fact it's just extensions of these cells. So it's important to find this space in between, right here, this infundibulum, this opening to look up into the frontal as we do in the different draft procedures. So in a primary case, it's very simple. You know that you want to stay at the coronal plane of the face of the bulla, or lower down the natural ostium of the maxillary that's around the tail of the uncinate process. You all saw that yesterday. And we want to head up against the vertical lamella of the middle turbinate. In this case, we've reduced the head of the middle turbinate just so that you can see the extent of the uncinate process. And I can tell you more and more in the United States, we see more and more people who used to not do anything to the middle turbinate, doing more to the middle turbinate, fully recognizing that the middle turbinate is really an extension of the ethmoid complex. And particularly when it is pathologically affected, more and more people are at least reducing the anterior head. Why? So that you don't fracture the lamella of the middle turbinate, and two, so you can see the structures of the middle meatus and do a safe surgery. The whole thing here is to get the patient better, but to do it in a safe manner. Let's see if we can get this going. Okay. So there are different variations of the uncinate, and you can see here where we have the uncinate, here's the uncinate process, ends prematurely right at the face of the suprabullar area. In other words, this is the bulla, there are cells that sit above the bulla, and the uncinate attaches here. Contrast it to this one where the uncinate goes all the way up and attaches to the vertical lamella of the middle turbinate. It probably doesn't make a difference where the uncinate ends medially here, because it's so variable, and because really the frontal recess, which is where the asterix is, the entry into the frontal recess, is going to be in the same coronal plane. It's still going to be roughly at the coronal plane of the face of the bulla or the ostium of the maxillary, as I noticed. The only difference is that secretions from the frontal in this scenario here will be entering the upper parts of this ethmoidal infundibulum behind the uncinate. Whereas here, where the uncinate ends prematurely, and you can see the asterisks here, the secretions of the frontal will drain directly into the middle meatus. And that's about the big difference. So if you know where if you see the maxillary atrocity, you know where the natural ostium is here, just behind the nasolacrimal, and just behind the insertion where you see that little letter A here of the middle turbinate, you want to go in this direction towards the frontal infundibulum, and that's between the anterior ethmoid artery, right making up the back wall of this last suprabullar air cell, and right behind the insertion of the middle turbinate, but you're going to do this medially up against the vertical lamella of the middle turbinate. Here's an endoscopic view of an Agranazzi cell. This is the insertion of the middle turbinate, Agranazzi cell. Just above it is a type 1 frontal cell, and we'll get into that in a second. So this is one column of cells, starting with the uncinate, Agranazzi, type 1 frontal cell. And remember that the lateral part of the uncinate inserts into the floor of the Agranazzi. So you merely have to follow the uncinate process up laterally on the orbital side, and you'll insert into the floor of this cell. And of course, if you keep going up through that cell, straight north, basically, you will be entering the frontal infundibulum. The other set of cells, the bulla, the suprabullar cells, are a tad bit more posteriorly. Only a little bit of the anterior roof of this last suprabullar cell really extends into the floor of the frontal infundibulum. If you go too far posteriorly, you will be entering in the area of the anterior ethmoid artery, and of course, that will go intracranially. So if you're going to err about going into the frontal, err on going too far anteriorly, not too far posterior. So the other thing, this is the left side of the nose. The way you put the probe to find your frontal makes a big difference. This is the wrong way on the left side to put your probe in. You should not be resting your probe on the orbital wall and inclining it this way. If you do it this way, the chances are of going in through the lateral lamella of the curviform plate is very high. Whereas if you rest your probe this way and you angle it supraorbitally, your chances are you will be going in the right direction of the frontal infundibulum, going over the orbit. So it's a matter of how you use your probes as well. So in revision cases, we really have to go by other landmarks. We certainly use the convexity of the nasolacrimal. We want to stay at the coronal plane of the natural ostium of the maxillary, just behind the lacrimal, and stay parallel to it, going up just behind the insertion of the middle turbinate. But we want to hug the middle turbinate with our probe and point the probe laterally, not medially. Again, you want to stay between the red shaded air cells and the green shaded air cells. The red shaded air cells are the uncinate, where it inserts into the floor of the Argonauzi, and then of course any other cells that may be above that. And you want to go over, if you want to really see the front, you've got to remove the dome, this upper dome of this cell, and go straight up. And to open it, the AP, you got to remove the dome of these upper supraorbital cells in the green shaded area. So if you look at a case like this, where it's got polyps, the arrows point to the nasolacrimal. This is the wrong, as I showed, area. I've already done the ethmoidectomy, taken the polyps out. This is the right direction on the left side that you want to go, hugging the middle turbinate vertical lamella. We use probes. Other people have used balloons to feel the frontal. It's a two-finger technique to feel the back wall, to dilate it, and then we use an angled microdebrider to collect the debris. We do not use the microdebriders to explore cavities. We do not use microdebriders to push. It's only to collect tissue. If you do use it to push, you can get into trouble with orbital injury. So these are the different cells that can occur at the level of the Argonauzi. Type 1 cell, of course, these are Kuhn's classification. And this is above the Argonauzi. 2 cells is above, type 2 if it's more than one above, and then the type 3 if it goes over the orbit, type 4 if it's an independent cell. And don't forget the inner sinus cell of the frontal. Some people can confuse this cell with the actual frontal, particularly when they're doing balloons and they transilluminate. You're taught when you use balloons to transilluminate over the orbit, not in the midline. If you transilluminate in the midline, you can be into one of these inner sinus cells. That's different than those that you transilluminate over the orbit. So the different types, of course, is the type 1 frontal sinusotomy, where you essentially do an ethmoidectomy, but preserve the dome of this last cell. It's the last suprabular cell or the last Argonauzi or type 1 or type 2 frontal cell, whichever is the last cell in that column. And you really are only opening up, you're only doing an ethmoidectomy and preserving the space between the medial wall of these upper cells and the vertical lamella of the middle turbinate, but you're not going into this upside down snow cone area here. That's the frontal infundibulum. So you never really look or transilluminate up into the frontal. So that's a type 1. And the kind of things that, the type of procedures that you would do, this happens to be an in-office balloon procedure where we go behind the uncinate, and we're just going to address this opacified frontal in a person who likes to dive, didn't want to go to the OR. We're just going to do some anesthesia. That's a little different talk for another day. And then we just balloon that area and suction out the mucus. So we stay behind the upper attachment of the uncinate process. We probe it, we balloon it, we dilate it, and then we look to make sure it is patent. And then the patient, of course, has this kind of results. We're just merely ballooning them in the office, and this spares them a visit to the OR. In a type 2A frontal sinusotomy, now you've removed all the ethmoidal cells all the way up to the dome, just so we can see where the asterisk is here, the frontal infundibulum. Many other names, including frontal opening, frontal ostium in the old days. The point is you're going to start looking up, and you're going to start looking as you remove the dome of this type 1 frontal cell. Sometimes it's just an Argonauzi cell, but if you remove this dome, you'll progressively look up and you see the frontal sinus. And don't forget that if there's an opening medial to that, that's probably an opening that goes to the intersinus cell. Don't confuse that with the frontal. Typically the frontal opening, the frontal recess opening, is the most medial and anterior opening. However, if there's an opening medial to that, And you found the frontal a little more lateral, and you can see this on CT, by the way, then it's probably an intersinus cell. And you can have intersinus cells draining on either side of the nose. In a type 2B now, it's basically a type 2A where we remove all the ethmoidal cells to look at the frontal infundibulum as we saw previously. The difference is we're removing this portion of the middle turbinate head and vertical lamella all the way up to the skull base. If you recall, the medial wall of the frontal infundibulum, so this wall over here, a little further anteriorly, so this wall right here is the medial wall of the frontal infundibulum. In order to enlarge the medial wall of the frontal infundibulum, you have to remove the base of this middle turbinate, right over here. So you have to remove this portion, and you can see it endoscopically below, where we've removed that portion of the middle turbinate to see the medial, where it inserts into the medial wall of that type 2A frontal sinusotomy. The main landmarks here, in order to go from left to right, right to left, whatever direction you want, is to learn to identify where are the anterior fibrils of the curviform plate that are marked by the little arrows here. And there's an exercise we do in the lab with the residents where we intentionally have them find that little edge. It's like a bony edge, and it's like a trough. It's a V trough. And you actually elevate, and you'll see the fibrils come in. Once you identify that, then you can remove everything anterior to that, and you can go from left to right through the junction of the perpendicular plate of the septum and the inner sinus septum up here, and extend this frontal sinusotomy all the way to the other side and actually go from left to right. If you just remove the bone over here, this triangular bone, but don't go to the other side, that may give you about 3 or 4 millimeters more medially, and that's what we call a draft 2B, okay? So we use a bunch of instruments, but probably the main instruments we use to do these extended frontals are the C-spine curettes. They come in different sizes, different angles. The orthopedic and neurosurgeons use it for the C-spine. They're very hard curettes. We get started with those, and then we do the finesse work with the angle drills that are available that irrigate and do the work. So in a draft 2B, we basically go through and start with removal of that portion of the middle turbinate. We remove this triangle right here in this area and extend it to a draft 2B. In a draft 3, we basically, it's a bilateral draft 2B. Okay? All we do is remove the inner sinus septum and where it continues as a perpendicular plate. So we do a bilateral 2B to communicate